My name's Evan Guerrero. I'm an orthopedic surgeon and kind of upper extremity specialist. And I'll be talking to you today about shoulder pain. They had a more catchy title than I did, but kind of common problems with the shoulder and solutions. Just a little bit of background on me. I'm a local person. I grew up in San Juan Capistrano and went to St. Margaret's. I went back east to college at Lehigh, which I hadn't heard of, but it's in Pennsylvania, and went there to play lacrosse. I went to Tulane University School of Medicine for medical school, and that was where I kind of got my first interest in shoulder surgeon, kind of working with Dr. Savoy, Buddy Savoy, who's a kind of a world famous shoulder surgeon. And I've kind of had that interest ever since. I did my residency at Duke University in North Carolina, and then did a upper extremity surgery fellowship that included hand and shoulder and elbow at Ortho Carolina in Charlotte. And now I'm practicing in Mission Viejo, and happy to be talking to you all today. So I'll get right into it, and I'll try to get through things pretty quick so we leave a good bit of time for questions. So we'll start with kind of rotator cuff tendinopathy. And I say tendinopathy because it's a spectrum of disease. It's not always tears. Sometimes it can be tendinitis. On one side of the spectrum, you have kind of tendinitis or mild partial tears. Then you can have kind of bigger partial tears, smaller full thickness tears, or large tears. So this is a big spectrum of disease. So it can happen from an injury, so a traumatic rotator cuff tear, or it can happen from degeneration over time. And sometimes it can happen from your acromion pinching down on that rotator cuff, which we'll have some slides on that later, called impingement. But this often presents with pain in the kind of the front of the shoulder and also in the side of the shoulder. And it often radiates down the arm. So I have a lot of patients who come in not sure if it's coming from their shoulder or their elbow, because it kind of radiates down their arm. But it tends to be bothersome with motion and kind of carrying certain items, and especially at night. And that's often when people are kind of driven to treat these, is because it just keeps them up at night and causes them a lot of trouble. That exam maneuver on the bottom right is, we kind of call it an empty soup can test. And if your arms are kind of at a 30-degree angle out from the front and you have your palms down, if it hurts when you're resisting that motion, pushing down like that guy is, that's a pretty classic sign for rotator cuff pain. Particularly that supraspinatus tendon that you see up top is the one that's most commonly torn, and that test elicits pain if you have a tear, that supraspinatus, or even just tendinitis or tendinosis. So that's something that I often do as the first thing to evaluate in clinic, is a physical exam, which usually gives us a pretty good idea of what's going on. Although it doesn't necessarily put you perfectly on that spectrum. I know that something's going on with your rotator cuff, but I don't know always whether it's a full thickness tear, a partial thickness tear. So we have ways to kind of further decipher that. Usually have a good general idea, but often need a little bit more information to know 100%. So treatment kind of depends on the etiology and the age of the patient and all those things to a degree. Like a traumatic tear, so shoulder pain and difficulty moving it after a fall, is something that we generally get an MRI right off the bat, because a large traumatic rotator cuff repair is something that we usually repair to avoid a certain type of arthritis that can develop if left untreated, which we'll talk about later. But most of the time if you're examining more like a partial thickness tear, or if you haven't had an injury, we often will start with physical therapy to work on kind of strengthening and stretching those rotator cuff muscles, some of those exercises shown to the right, as well as oral or local or topical anti-inflammatories, to kind of see if we can't get you feeling better that way. Usually at that point, if that's not working, MRI will usually be the next step to kind of confirm where you are on that spectrum of disease. I put steroid injection with a question mark. A lot of these things we can go straight to a kind of steroid injection to make you feel better, while you're doing therapy. But there's some evidence in rotator cuff repairs that the results of a rotator cuff repair is not as good after a steroid injection. So I'll often wait until after we get the MRI to offer a steroid injection, just in case you have a big full thickness tear and it's looking like you'll need surgery. That way we don't kind of worsen our rotator cuff repair outcomes. But if you have a partial tear or just tendonitis on MRI, then, and it's not a traumatic mechanism, then those steroid injections are often really helpful. And then finally, if it's a large traumatic tear, then we kind of go straight to surgery for that repair. But otherwise, it's usually just if we've kind of failed these non-operative treatments and it's still not getting better, that's when we do surgery. And I'd say debridement or repair. Most of the time it's repair, just because a lot of the times the partial tears get better with these non-surgical treatments. But if they don't, sometimes you can just kind of clean up the rotator cuff tear and any other pathology that's in the shoulder. But if there's a full thickness or near full thickness tear that fails conservative treatment, a rotator cuff repair is the answer there. And this next slide shows you kind of how we do that. And it shows the picture on the left is kind of, and on the top center, I guess, shows the little, those little lines are some of the holes we make along, and then kind of drawing of some of the anatomy where some of those portals are. These are kind of 1 centimeter incisions, 1 to 2 centimeter small portal incisions. And that's where we look through the camera and also have instruments that work through there, like you see in the top center. And then that bottom right is a picture of kind of a classic way of how we do the repair. And you know, the constructs can be a little different depending on the size of the repair. But this is a pretty common one, is those 4 suture anchors. So anchors that go into the bone, and then the suture that goes up through the tendon, and then is kind of secured down, and it kind of squeezes that torn rotator cuff that sometimes is pulled back down onto the bone where it goes. And then I'll talk about the recovery period afterwards, kind of at the end, how we kind of protect this repair afterwards. But I'm going to kind of go through some of the other pathology that goes along with this before we get to the recovery, because a lot of the recoveries are similar, so about after these surgeries. So we'll kind of run through them at the end. So this is that impingement that I was talking about with the acromion and the rotator cuff. I actually, that bone spur is not a great picture, because the kind of impingement generally comes from the acromion. So that top left picture is not super accurate. So I apologize for that. I'll have to change that. We can thank the Cleveland Clinic for having a kind of being a little bit off on that one. They're usually pretty spot on. But this is something that often comes along with these rotator cuff tears or tendonitis. And basically the acromion can be downturning, and it can cause that acromion to pinch on your rotator cuff when you lift your arms certain ways. And it's kind of a chicken or the egg type situation. It's kind of debated in the shoulder world whether the rotator cuff issues come first and the spur and the acromion kind of reacts to that, or whether that acromion kind of pinches down and causes those rotator cuff tears. And you can see the general idea of that on the top left. When this is isolated and it just has kind of tendonitis and some impingement, often physical therapy with or without a steroid injection can make this feel better. But if it causes a full thickness tear or if it's just not getting better without surgery, the surgery is a shoulder arthroscopy, and then we take out some of that inflamed bursa. So the fluid-filled sac that's above the rotator cuff gets inflamed, and then we just smooth out that acromion with a little burr so that it's not pinching down on the rotator cuff anymore. A classic kind of test for impingement is the one pictured on the bottom left. That's called a Hawkins test. And that basically, if you have that impingement, that elicits pain in the shoulder. And then the near test is on the top right. And like I said, this is most commonly treated along with rotator cuff pathology. Acromioclavicular or AC joint arthritis is another thing that often we see along with other pathologies in the shoulder. I see a ton of this on x-rays, but it's commonly not symptomatic. The kind of classic test is cross-body adduction, like you're seeing on the top right, but it really is tender right there over the end of your clavicle at your AC joint, rather than deep down in the shoulder if this is symptomatic. If this is symptomatic, I'll often do a steroid injection into this joint for two reasons. One is that it can make it feel better and stay better. The other reason is I want to know how much of your pain is coming from this, because if your pain is all coming from the other pathology from your shoulder and not from your AC joint, then I'll just leave it alone in surgery. But say it's bothering you a lot, it gets a lot better with steroid injection, then that's something that we'd address with a distal clavicle excision, which you can see kind of the arthritis on the top left, where that joint space is narrowed and there's a bone spur kind of at the bottom there. Versus in the bottom screen where you take off the end of the clavicle and you can see a much larger space there. But I will say as a caveat, I see a bunch of AC joint arthritis on x-rays, and it's a small percentage of them that I end up having to treat surgically. Biceps tendonitis, this one's really common, and it can occur on its own, but also occurs with rotator cuff pathology, so often along with rotator cuff tears or tendinopathy like we talked about, or with superior labral tears, which we'll kind of discuss some more on an upcoming slide. This commonly occurs as kind of anterior shoulder pain, kind of in the groove, and it can radiate down the front of the arm. It often gets better with therapy, and you're probably catching some common themes here, but it commonly gets better with therapy with or without steroid injections if it's isolated. If it continues to be bothersome, or if you have other pathology that needs surgery, there are two options to treat this. One option is just to cut the biceps tendon up where it's inside the shoulder joint, like you can see on that top left picture. And then the tendon naturally retracts outside of the shoulder. So you can just let it retract there, and you don't have that inflamed tendon in the shoulder joint anymore. And that tends to get rid of the pain. Sometimes we'll reattach it outside the shoulder joint just to kind of restore the contour of the arm. But it's actually something that interestingly has been really well studied, and the difference between the two, whether you reattach it or just cut it and let it retract back and scar there, they've shown no differences in really good, well randomized studies. So the results functionally and even cosmetically are the same. So most of the time, my kind of general rule of thumb is if it's not the primary pathology and I'm doing it along with the rotator cuff repair, I'll often just do a biceps tenotomy to kind of save time, and the results are about the same. If it's the primary pathology, like we're going in for biceps tendonitis and maybe a superior labral tear, then I'm more likely to reattach it outside the shoulder if that's kind of the main thing we're addressing. But there are pretty good studies to say that both do about the same or very similarly. Superior labral tear, you may have heard of it if you're a sports fan, called a slap tear. And what that kind of stands for is a superior labrum tear from anterior to posterior. So it tears kind of front to back in the shoulder. And I don't know how well these pictures show it, but your labrum is basically, so your socket's kind of like a clock face and the ball kind of fits inside of it. The labrum is a tissue that goes all the way around the socket. And the superior labrum is a common place to get tearing there because the biceps tendon attaches right on it, kind of like you see on that top picture there. And then that biceps tendon kind of pulls on that torn labrum, and it can be quite bothersome. This is often patients will have this when lifting weights, sometimes overhead athletes, but it can really happen in anybody. And it's usually pain with activity, especially with overhead activity. And this often responds really well to therapy with or without a steroid injection. I had one of these, and I could not throw a ball for 6 months, but I kind of waited it out and it got a lot better. That's mostly because I'm stubborn. Most of my patients end up going for a steroid injection and some therapy, and they tend to get better quicker than I did. If surgery is required, the treatment for most patients, so 95+% of patients, is to cut that biceps plus or minus reattaching it outside the shoulder, and then just cleaning up that superior labrum. So basically just getting rid of that force that's pulling on it and kind of cleaning up the kind of frayed edges. And that's been shown to work really, really well. Sometimes in really young athletes, like, 18-year-old pitcher, will consider doing a repair, but that's something that the pendulum has shifted big time on it. It was the French who started kind of being more and more likely to do the biceps tenotomy or tenodesis and debridement instead of repairing it. And they've shown that the results are a lot better, especially people, who are kind of in their 30s, 40s, or older. And the reason is, if you repair that superior labrum, the tendency is for folks who are not very young to get stiff. So it's a much simpler procedure to kind of address the biceps tendon and just to clean it up, and the results are really good. The classic test for this to see kind of if you have it is called an O'Brien's test, and that's what it's showing on the bottom right. And it's kind of a complicated test because for it truly to be positive, you have to have pain deep in the shoulder with resisting downward pushing with that maneuver, and less pain when you turn your palm up. So a lot of the time, both hurt, and this exam is kind of equivocal. But if you have pain when resisting being pushed down with your arm across, that often indicates some superior labral pathology. Adhesive capsulitis. This is, if you've heard the word frozen shoulder, is another word for this pathology. And it commonly happens in folks with diabetes. And basically what happens is the shoulder becomes really painful, and then later it becomes really stiff. And this is one that's a little bit frustrating to treat. The good thing is that it usually gets better without surgery, with therapy, with a lot of stretching, with or without, usually with steroid injections, because this can be really hard to stretch well without the steroid injections to kind of calm things down. And it often gets better without surgery, but it can take up to a year or more. You see those stages, and there's a big kind of variability in how long each of these stages lasts. So it usually gets inflamed where it's really painful, and then the pain often gets a little bit better, but it gets really stiff. And then finally, the range of motion gradually returns. I'll usually have people do a minimum of 6 months of therapy before we even consider surgery for this, because so many of them get better, and even up to a year. But that being said, with surgery, either with a capsular release, so basically just cutting parts of that capsule to free it up, or they've shown the results to be pretty similar with just a manipulation under anesthesia, where we really slowly, carefully move that shoulder to get more range of motion, and it kind of tears that capsule. Shoulder arthritis. So this is something that can come from just kind of normal wear and tear, just like any other joints. It can also be related to previous injuries or surgeries, or sometimes inflammatory arthritis, rheumatoid arthritis, psoriatic arthritis. There are other etiologies like old infections, things like that too, but those are kind of the most common ones. Pain and stiffness are common symptoms, and sometimes you can even hear that kind of creaking of the joint, of those bones kind of rubbing together. The x-ray on the top right is kind of a classic x-ray for this, where the joint space, usually there would be space between that kind of ball and socket that you see there, and there's no space there. Before that joint space is completely worn out, what you see earlier is that what we call an inferior humeral head osteophyte. So basically that little bone spur that's on the bottom of that, on the bottom inside of that head, if you can see that. We call it it's kind of jovially called a goat's beard, because if you look at the humeral head kind of like a goat, it looks like a little goat's beard coming off the front. X-rays are really all you need for the diagnosis for this. Sometimes we'll get an MRI to evaluate the rotator cuff, how to evaluate kind of the integrity of the rotator cuff. But usually with classic arthritis like this, the rotator cuff is spared. And then sometimes we'll do a CT scan to evaluate kind of the bony anatomy if we're kind of planning for a shoulder replacement. And so similarly to the other, and I know you're getting tired of hearing it, but therapy and steroid injections are often where we start with this. PRP is something that's not really well studied in the shoulder. For shoulder arthritis, there are some case reports, but there are no real good studies validating it yet. I know there's currently a big trial going on for it, but the results haven't been published yet. Similarly with hyaluronic acid, or kind of the visco supplementation, there isn't great evidence behind it. So it's not something that I routinely do, but some patients who have had success with it elsewhere will really want to try it. And it's not super harmful. So it's not, I'm not against doing it, but there's not a ton of great evidence behind it. Finally, people who are kind of in their 60s, 70s do great with shoulder replacements. Honestly, some of my happiest patients who are more in their 30s, 40s, and early 50s, who get kind of that early arthritis, not with an x-ray like you saw on the last page where there's no space there, but if they just have a little bit of a bone spur, maybe some other pathology in the shoulder, there's some evidence that an arthroscopic cleanup, so debriding things, addressing any biceps tendonitis that they have, can help the pain for a couple years. And if that's somebody who's 51 years old, and maybe you can get them till they're 55 before doing a shoulder replacement, that's not an unreasonable treatment option. But in general, if you're in your 60s or 70s and you have shoulder arthritis that fails conservative management, a shoulder replacement's going to be the right answer. And like I said, these are really happy patients after the shoulder replacement. What you see on the right here is what we call an anatomic shoulder replacement. And that's kind of the traditional for classic arthritis like this, basically where the ball is replaced with a ball. You see that kind of metal ball on the left there with the stem that goes down into the humerus, a metal stem. And then the glenoid component, the socket, is replaced with a socket. And it's usually that kind of plastic plus or minus a metal backing to it, depending on which company you're using. On the bottom right, you see sometimes in younger patients, we'll use a stemless, just if they have really good bone quality and they're real young, we don't always need to use that stem, but most of the time it looks like the one on the left. But then as I was saying, the reverse shoulder replacement is becoming more common in folks who are a little bit older, or if there's some question about the rotator cuff integrity, that's what we'll go to, and I'll get to that in a second. So rotator cuff arthropathy, and this was where that reverse shoulder replacement was invented, is a typical pattern of arthritis that's often comes with untreated large rotator cuff tears, especially those traumatic ones. So people fall, they get a big rotator cuff repair, and they kind of ignore it. It tends to lead to this kind of traditional pattern of arthritis pretty quickly, where you can see on that top picture how that humeral head is really elevated related to where the socket is. And that kind of wears out the joint very quickly when it's kind of not sitting flush. Because the rotator cuff, really, one of its main jobs is to kind of center that head inside the socket and to kind of squeeze it in there. So it's kind of a dynamic stabilizer. So when you don't have that, so when you have a big tear and you don't have anything on the top of the rotator cuff, it comes up. With smaller tears, so if you have a partial tear or just, a small tear that isn't really retracted, it won't kind of elevate like that. So that gives us some more time. That's why we're able to kind of treat those other ones non-operatively to start. Versus if you have a traumatic rotator cuff tear that's large, that's one of the few times that I might recommend surgery within the first time or two that I meet you. Like I said, if it's not a huge traumatic tear, you can still attempt non-operative treatment. Or if somebody's, maybe 85 years old and even if they have a large traumatic rotator cuff tear, we might try to treat it non-operatively to avoid a surgery and then do the replacement if it doesn't work. But that's kind of the typical pattern of arthritis. If you already have rotator cuff arthropathy, so the rotator cuff tear and arthritis, then the rotator cuff repair is not a good solution because that doesn't treat the arthritis. The shoulder will get stiff and it won't make you better most of the time. So if you have a large rotator cuff tear and arthritis, or a failed rotator cuff tear, repair, and arthritis, we usually go to this reverse shoulder replacement. And it's really one of the greatest advancements we've seen in shoulder surgeries, that was made specifically for this, because basically the total shoulder, anatomic shoulder replacement won't work without a rotator cuff that's functioning. And trying to replace the shoulder and fix the rotator cuff just wasn't found to work very well. So Dr. Neer, who you heard his test named after him, came up with, and some real smart guys came up with this reverse shoulder replacement, where basically you change the socket into a ball, and then the ball into a tray or a socket, and hence the kind of reverse shoulder replacement. And what that does is it allows your shoulder, since it brings it kind of down and in medially, it allows your shoulder to function without a rotator cuff. And some other benefits to it is that it's inherently a little bit more stable than the than the classic total shoulder. Other benefits is that it's easier to get really good fixation in the glenoid. So basically in the socket part, you saw on the other slide, you're asking for that little plastic piece to kind of go into that small, relatively small bone. So in folks with poor bone quality, the reverse shoulder replacement is a more reliable option. So the pendulum, once again, is really swung towards doing this a lot of the times, even for primary arthritis, not rotator cuff arthropathy, especially in folks who are older. If you're about 70 years or older and you have shoulder arthritis, most of the time you're going to be getting a reverse shoulder replacement, just because it's a little bit more reliable in terms of getting that glenoid to heal nicely the component to heal nicely onto that glenoid. And also there are some other things about it, like you're not in a traditional shoulder replacement, you have to get one of the tendons that kind of keeps things in place to heal. And then this one, you don't really have to. So there are a lot of good things about it, but in general, if you're in your 50s or 60s and kind of your 50s, early 60s and kind of on the early side for a shoulder replacement, and you have that classic shoulder arthritis, you'll probably get the anatomic. If you're in your later 60s or older, or if you have any history of instability, or your bone quality is maybe not as great, or if you have some kind of deformities, we have a pretty low threshold to go to a reverse shoulder replacement. And the main reason is just because they are really reliable and do really well. So we talked about kind of the post-operative, or the tip, we kind of beat this one over the head, so I won't go into it for too long. But in general, if you come in with shoulder pain to my clinic, we'll do a good exam. We'll get some x-rays to see if we have arthritis. And then with the exam, I can usually have a pretty good idea of what's going on in your shoulder, although maybe not like I said, if it's a rotator cuff related, I might know that you have a rotator cuff problem. And I may have an inkling that it's, where it is on that spectrum from tendonitis to a bigger tear. But usually I have a good enough idea to kind of allow you to have targeted physical therapy. So I would refer you to physical therapy, and often it's rotator cuff strengthening, stretching, but they do a little bit different therapy depending on what the pathology is. Sometimes scapular stabilization and different things like that. Like I said, if it doesn't seem like it's a rotator cuff tear, then I will, and it's something that's keeping you up at night and really bothering you a lot, I'll often offer a steroid injection, or offer to allow you to do therapy for a little while and do the steroid injection if it's not getting better. And then the MRI is the way that we usually, if you don't have arthritis, if you have arthritis, we already know on the x-ray. If it's something soft tissue related, the MRI is usually how we confirm the diagnosis, but often we can get it to feel better with therapy with or without a steroid injection and not even ever have to get an MRI. But if we've tried all that conservative management, we get an MRI, it confirms the diagnosis that we think it is, that's when we start to kind of think about those surgeries. But sometimes, sometimes the problem's a little bit different than what we expected based on the exam. and that can sometimes guide further non-operative treatment or a surgery. So we usually try pretty hard to get these feeling better without surgery. Some pathologies like full thickness rotator cuff tears or real bad arthritis just have a tough time getting better with non-operative treatment because it's a real mechanical problem. But a lot of the other pathologies do get better without surgery, and we're usually willing to try. And then finally, the post-operative course. So there are kind of two categories that I kind of put things in terms of the post-operative course. And one is repairs and one is debridements or kind of cleanups. If it's just a cleanup with or without the biceps tendonitis, so that one for our therapy protocol doesn't really count as a repair, even if you get that biceps tendon repaired outside your shoulder. Those ones we kind of allow you to do immediate active motion. So you're able to move your shoulder, you're working with therapy on stretching right away. We keep things light to try to avoid the shoulder kind of swelling too much, but we don't really have a repair that we're really having to protect in a big way. So we let you do more right off the bat. On the other side of things is the repairs, and those we generally have to protect a little bit. Like a rotator cuff repair, for example, I'll usually have you in a sling most of the time for the first 6 weeks. So you take it off to shower, and you're able to do some stuff kind of in this area without your arm going way out or up. So, brushing your teeth, a little bit of stuff with the hair, with your elbow at your side, you're allowed to do kind of right away. You're allowed to move your wrist, hand, elbow, but you're in the sling most of the time otherwise. Therapy kind of moves your arm for you a little bit, but you're not actively moving your shoulder a whole lot to keep that tear from kind of pulling out or pulling off. And then at 6 weeks, you get the sling off, you start to move it and do light activities. You still keep it light. Then you begin strengthening at 8 weeks. And usually by about 3 months, I'll let you do most things as you want to do as pain allows. But they really get better even up to 6 months or a year after surgery. The shoulder replacement is actually, people are usually surprised to hear that it's a little bit quicker of a recovery than the rotator cuff repair often. So if somebody's way older and have a big rotator cuff tear that fails non-operative treatment, often a reverse shoulder replacement is a better answer for those folks, because a reverse shoulder replacement, I have you in a sling kind of under that same rotator cuff repair protocol for about 4 weeks, and then you're kind of able to start moving a little quicker. And those folks, like I said, it definitely, your motion gets better every bit of 3, 4, 5, 6 months after surgery, but the pain relief is actually much quicker than a rotator cuff repair. So the shoulder replacements, for whatever reason, I think there's a lot of kind of, talk about them, maybe some bad press about them. But honestly, it's a really good option and people feel better really quickly. It's just mostly getting them kind of over the hump of kind of the stigmas behind a shoulder replacement, but they really do well. But those are kind of the general after surgery protocols. Obviously, if we were talking about surgery more specifically, we would talk about the specific one if we were getting ready to do surgery, if I was seeing you in clinic. And then finally, just kind of take home points, and I'll leave a bunch of time for questions. There are a lot of effective treatment options for these problems. They're not necessarily something you need to just live with. A lot of people are nervous to go see an orthopedic surgeon because they're afraid they're going to tell them, that they need surgery, and a lot of orthopedic surgeons, some will. I really try to do everything we can to maximize non-operative treatment, except for a few kind of exceptions like we talked about. But most of the time we're able to get things feeling better without surgery. And then if we're not, and it's bothering you enough, that's when we start to talk about surgery. Just kind of as a shameless plug, I also do a lot of hand, wrist, and elbow surgery and treat kind of other problems. So I'd be happy to see anybody pretty much for any issue in arms or legs, but my upper extremity is my specialty. And that's my coordinator's number. We've had some, the phone lines are a little bit challenging right now. So that's kind of a shortcut to get to my coordinator to schedule an appointment if you're interested.